Welcome back to the deep dive. Today, we are tearing into a single patient case study, a complex, almost agonizing clinical choice.
Yeah, this one is pulled right from the pages of the New England Journal of Medicine, and it's a real classic.
It's not just about applying some formula, is it? This is
Yeah.
life and death calculus, where doctors have two effective but, well, equally dangerous options.
That's right. Our sources present, the quintessential challenge in modern vascular medicine,
Which is what, exactly?
how to safely and effectively treat symptomatic high-grade carotid artery stenosis. We're talking about a blockage that's 70% or more.
In the main artery to the brain.
Right, in the internal carotid artery.
Yeah.
And crucially, this blockage has already thrown off a huge warning sign.
So we've got a patient with a ticking time bomb in their neck, and the clock is demanding urgent action.
It really is.
And the choice. The fundamental choice facing the clinical team is between what? The traditional open surgery
Yep, carotid endarterectomy, or CEA.
versus the more modern, minimally invasive approach.
Exactly. The catheter-based approach, which is carotid artery stenting, or CAS.
And our mission for this deep dive is to analyze the case of one specific patient, a 75-year-old woman, and then dive into the expert opinions arguing, forcefully for both procedures.
And it really forces us to weigh the known immediate procedural risks, which are wildly different between the two methods.
Against the long-term devastating potential of an untreated stroke.
It's the ultimate medical balancing act.
Okay, let's unpack this. We have to start with the full picture of the patient because in this kind of dilemma, the blockage itself is only half the story.
The comorbidities, they're the other half of the problem.
Exactly.
Okay, so let's start there.
So let's introduce our patient. What brought this 75-year-old woman into the hospital? And I guess, how urgent was the situation?
She presented with a brief, and I mean a terrifying event,
Yeah.
a 15-minute episode of expressive dysphagia.
Expressive dysphagia. For those listening, that means she suddenly couldn't speak, right? She couldn't form words.
Exactly. She lost the ability to articulate thoughts or produce coherent language. It's a clear, classic sign that the left hemisphere of her brain, the language center, was deprived of blood flow.
And the fact that it resolved completely, that's a bit of a double-edged sword, isn't it?
Oh, absolutely.
I mean, it's a relief, of course, but it absolutely confirms the severity of the underlying problem.
That's the key point. Because the symptoms fully resolved, and because the MRI she got later showed no sign of acute infarction.
Meaning no permanent brain damage yet.
Yet, that's right. She was diagnosed with a transient ischemic attack, or TIA.
Which people call a mini stroke, but medically it's more like a maximal warning, isn't it?
It is the maximal warning. TIA patients are at an extremely high risk of a major debilitating stroke within the next, say, 48 hours to a week. The clock is ticking loudly.
And the source of this terrifying warning, what did they find?
Vascular ultrasound and a CT angiogram confirmed it. A high-grade stenosis, a blockage of 70% or greater in her left internal carotid artery.
And the cause is just plaque buildup.
Yeah, classic large vessel atherosclerosis. So the urgency for revascularization, for clearing that blockage, is, well, it's undeniable.
Now, the sources mentioned that her anatomy was favorable for stenting. Can you break that down for us? What does favorable anatomy even mean here?
Yes, this is a really important point for the pro-stent argument later. The imaging was very reassuring about the approach to the blockage.
Okay.
Her aortic arch was a type I, which is basically the easiest on-ramp for a neurointerventionalist to navigate a catheter through.
So a straight shot, more or less.
More or less. And crucially, there was no significant tortuosity, no severe winding turns in her vessels. And the plaque itself was described as lacking dense calcification, or an adherent thrombus.
An adherent thrombus being a blood clot stuck to the plaque.
Right.
And if a plaque is heavily calcified, it's hard, right? It's like trying to put a stent in a rock.
Exactly. You risk shattering that hardened material, and those fragments can cause a stroke right there on the table. So the lack of calcification here is a major point in favor of CS.
But as you said, the decision hinges on more than just the artery. Let's shift to the patient herself. What's the list of coexisting conditions that transforms this from a standard surgical case into this high-stakes clinical dilemma?
It's a lengthy list, and they all complicate things, especially general anesthesia and major surgery. The top concern is her chronic obstructive pulmonary disease, COPD.
And she's a former smoker, too.
Quit 10 years prior, which suggests a history of lung damage that just compounds that COPD risk.
Okay, so why does COPD specifically raise these huge red flags for the surgical option, for CEA?
Because CEA requires general anesthesia. And when you put a patient with COPD under, you are essentially asking their already compromised lungs to manage a ventilator for hours.
Right.
They face a significantly increased risk of post-op respiratory failure, prolonged intubation, and aspiration pneumonia. These are life-threatening, non-neurological complications.
So you could fix the artery perfectly and still lose the patient to a lung problem.
You absolutely could, and that can easily negate the benefit of this successful stroke prevention.
And it's not just her lungs, is it? What else is stressing her system?
Well, she's managing insulin-treated type 2 diabetes and hyperlipidemia. That points to systemic vascular disease. It affects her ability to recover. And she also has mild renal impairment.
Mild renal impairment. That seems subtle, but it's another critical factor, isn't it?
It is, because if the team chooses CAS, the stenting option, they're going to use an iodine-based contrast dye during the procedure.
And that can be toxic to already impaired kidneys?
Precisely. So if they choose CAS, they have to minimize the amount of contrast used to protect her kidney function. We have a true dilemma here.
It sounds like it. The CAA procedure puts her lungs at risk.
And the CAS procedure risks her kidneys and potentially her brain because of that risk of knocking debris loose.
Even with the favorable anatomy.
Even with favorable anatomy.
And yet, despite all these challenges, she has a good quality of life to return to. She's independent, lives with her spouse, no cognitive impairment.
This is a person with significant reserve, you could say. And it makes preserving her cognitive function even more critical.
So when clinicians face this kind of complexity, they need objective numbers, right? Risk stratification. How did the standard calculators assess her risk for the surgery, for CEA?
The initial assessment classified her overall surgical risk as moderate. But, the raw numbers, they paint a more sobering picture.
Okay, let's break them down.
They used the American College of Surgeons surgical risk calculator. It estimated a 5.4% risk of a serious complication for a major surgery.
5.4%?
And then there's the Euroscore 2, which specifically looks at cardiac operative risk. It gave her a score suggesting a risk of in-hospital death of approximately 3 to 4%.
Wait, a 3 to 4% risk of in-hospital death?
Death, yeah.
Just from the procedure? That's not a risk of minor bleeding. That is the risk of mortality.
Right.
That figure alone, that provides the entire foundation for the CAS argument, doesn't it?
It absolutely does.
It immediately raises the question, is avoiding a future stroke worth a 3–4% chance of dying right now from surgical complication?
It's a huge barrier, especially when the goal is prophylactic, right? You're trying to prevent a future event. And that forces the physician to look at the alternative, CAS, even if it carries its own known risks.
So let's define the crux of this entire deep dive. Both procedures are available, the operators are highly skilled, the decision boils down to the methodology.
The defining factor is anesthesia. That's it. Carotid endarterectomy, the open surgery, it necessitates general anesthesia.
Total unconsciousness, muscle paralysis, ventilation, the works.
The works. Whereas carotid artery stenting, the percutaneous option, is almost always done using conscious sedation.
So the patient is relaxed, maybe a little drowsy, but breathing on their own.
Breathing on their own and able to follow commands. It's a world of difference.
So given her COPD, the need for general anesthesia in CEA isn't just an inconvenience, it's a clinical liability.
It's the highest liability. The presence of COPD means that the surgical team is accepting a significant, defined risk of a respiratory disaster.
Right.
So if the CAS option can deliver stroke prevention with a comparable or even a slightly worse neurological safety profile, but it eliminates that respiratory risk, well, the decision tilts heavily toward the stent.
And that's the central conflict we have to explore now, backed by two sets of very contradictory data.
Exactly.
Okay, let's start with the argument for surgery. We have Dr. Gert J. DeBorst, who recommends CEA, and his recommendation is based on, well, it seems like decades of robust randomized trial data.
That's right. His focus is on long-term safety and absolute stroke prevention. His whole perspective is anchored in this long-term population-level view.
And what's his core principle?
His core principle is that the procedural risk you accept, it must be substantially lower than the risk of the disease itself.
Okay, that makes sense.
And since symptomatic carotid stenosis carries this massive immediate risk of a debilitating stroke, the intervention you choose has to be the one that provides the most reliable long-term protection.
So he's saying you can't let the fear of procedural complication outweigh the known statistical benefit, the benefit of preventing the worst possible outcome, which is a major stroke years down the line.
Exactly. It's a net benefit calculation. The sources highlight that the long-term data overwhelmingly shows CEA is superior for the primary goal. stroke avoidance.
So for him, CEA should be the default choice.
It should be the default, unless a patient has, an anatomical reason they can't have it, or a medical risk so extreme they're unlikely to even survive the immediate procedure.
Okay, let's zero in on that immediate risk zone, the first 30 days post-procedure, because that's where the debate really starts.
Yeah.
What did the major trials consistently show?
In every major randomized controlled trial comparing CEA versus CAS in symptomatic patients. So the exact type of patient we have here. The risk of stroke or death within that initial 30-day period was significantly and consistently higher after CAS.
Consistently?
Consistently. This isn't a nuanced point. It's the most foundational difference between the two. Neurologically speaking, the procedure itself is safer if it's done surgically.
Why do the CEA proponents put so much weight on that 30-day window?
Because the stroke you suffer during or immediately after the procedure is often catastrophic, and it's preventable. If the procedure designed to prevent a stroke actually causes one,
It's the ultimate failure.
it is. The higher procedural rate with CAS means the stenting procedure, regardless of skill, inherently carries a greater risk of plaque manipulation and debris getting knocked loose.
Compared to the surgical technique, which just, cuts the plaque out entirely?
It excises the plaque entirely. You remove the source of the problem.
Okay, so let's track those risks over time. Does CAS ever catch up to CEA in terms of safety?
Well, when researchers do these pooled analyses, where they combine all the data from multiple big trials, they consistently find that initial safety gap favoring CEA, it compounds over time.
So it gets worse.
The absolute treatment difference in stroke risk at 1 year, 5 years, and even 9 years out consistently favored CEA. The gap was between a 2.8% and a 4.1% absolute risk reduction.
A 4.1% difference over 9 years is. That's substantial when you're talking about avoiding a stroke.
It's huge.
But I remember the source material saying that after that initial 30 days, the annual stroke rates were pretty similar. How do we reconcile those two facts?
That's a great question. And it really speaks to the power of that initial procedural risk. Post-procedure, after 30 days, you're right. The annual rate of a new stroke on the treated side is almost identical.
What are the numbers?
It's 0.60% for CEA versus 0.64% for CEA versus 0.64% for CES. Basically a wash.
So why is CEA better long-term?
The long-term superiority of CEA is entirely driven by the fact that the CAS group started with a higher number of procedural failures. They had more strokes during that initial 30 days, and you never recover from that initial deficit.
Got it. Okay, to understand why this procedural failure rate is higher with stenting, Dr. DeBourse dives into the data from a huge study, the International Carotid Stenting Study, or ICSS.
Yes, ICSS is crucial. It showed the sheer size and the risk differential. Procedural stroke within 30 days occurred in 7.3% of CAS patients versus 3.3% of CEA patients.
Oh.
But the really deep dive here is the mechanism. How did they happen?
Okay, but first, 7.3%. That is an alarmingly high number.
It is.
And where and when did these strokes actually occur? Was it all on the table during the procedure?
No, and that's the key point. The strokes were, predictably, mostly ischemic blockages. But out of 77 total ischemic strokes, 57 of them happened in the postoperative phase.
Day 1 and beyond.
Day 1 and beyond. This is why just avoiding the operating room doesn't automatically make CAS safe. The risks continue.
So if the patient is already off the table, what is causing a stroke days later?
Well, the sources outline a couple of distinct mechanisms. First, you have hemodynamic causes.
Meaning blood flow issues.
Right, related to blood flow dynamics and blood pressure instability after the vessel has been opened up. And these were way more common in the CAS group, 15 cases, versus only 5 in the CEA group.
And why would that be?
It might have to do with baroreceptor dysfunction. Those are the mechanisms in your neck that regulate blood pressure. They can be more affected by the trauma of the stent or even just the presence of the stent itself.
Okay. What's the other cause?
The other one is hyperperfusion syndrome. This is fascinating. It happens when the brain, which has been starved of blood flow for a long time, suddenly gets a torrent of blood after the blockage is cleared.
And that rapid pressure change can cause brain swelling or even bleeding.
Exactly. And interestingly, this was actually more common in the surgical group 6 cases versus 3 cases in the stenting group.
That is a subtle but important finding. So surgery carries a higher risk of hyperperfusion, maybe because the plaque removal is more sudden and complete?
That's the theory. Stenting might be a more gradual reopening, but the data is still clear. CAS has this unique and higher burden of late ischemic strokes related to those hemodynamic issues.
Okay. Now let's move to a factor that a lot of CEA proponents feel: well, that it seals the argument for them. And that's the issue of silent cerebral ischemia.
Yes, the long-term invisible damage caused by stenting.
So we're talking about finding new brain lesions on an MRI that's taken after the procedure, even though the patient has no outward symptoms of a stroke.
That's exactly right. An imaging sub-study of ICSS showed a staggering disparity here. CAS patients were nearly 3 times more likely to have new ischemic lesions on their post-procedure MRI.
What were the numbers?
The numbers were 50% for CAS versus only 17% for CEA.
50%. Half of all CAS patients suffered new detectable brain injuries, even if they couldn't feel it, that is. That's a profound finding.
And here's the implication that makes that data so terrifying.
Okay.
The presence of those new lesions in the CAS group was associated with a nearly triple risk of a recurrent stroke and TIA in the years that followed.
A triple risk.
And crucially, that correlation with the silent damage predicts a future major stroke was not observed in the CEA group.
Wait, why would a silent stroke predict a bad outcome in a CAS patient, but not in a CEA patient? That doesn't make sense.
Well, this is the prevailing hypothesis among the CEA advocates. Stenting, just by its nature, involves running wires and deploying a device through diseased plaque.
Right.
And that leads to a higher release of microemboli, these tiny fragments of plaque or clot. Those emboli cause the small silent infarcts.
So if a patient is prone to this debris coming off during the procedure,
it signals an inherent vascular or plaque instability that is likely to keep causing problems later. The CEA procedure, by contrast, removes the source of that unstable plaque completely.
So even if other trials show long-term equivalence in some combined outcome, CEA proponents point to this data and say, look, CAS is leaving patients with a higher baseline of cumulative brain injury, and that will eventually manifest as a higher long-term neurological risk.
That is their argument in a nutshell.
Okay, let's loop back to our patient's biggest challenge. Her COPD, diabetes, all the reasons given to avoid general anesthesia.
Right.
Dr. DeBourse argues that this whole idea that CAS is safer for high medical risk patients is actually a misconception.
Yes, he challenges the whole definition of risk. He points out that the criteria set by, say, the Centers for Medicare and Medicaid Services, CMS, to define high medical risk for CEA, they often overestimate how well CAS works in those same patients.
So he's saying that avoiding general anesthesia doesn't automatically mean a safer overall experience for a physiologically fragile patient?
Exactly.
What data supports that pretty dramatic claim?
The sources cite a large study of over 10,000 patients who met those very CMS high-risk criteria. And among that cohort, the patients treated with CES actually had a higher risk of stroke than those treated with CEA.
That is deeply counterintuitive. We're being told that if the patient is high risk, they should avoid surgery. But the data suggests that even if you take that risk and do the surgery, they have a lower chance of stroke than if you stent them.
And the disparity is even more extreme when you isolate the patients who are symptomatic, like our patient, and truly physiologically high risk.
Okay, what were those numbers?
Symptomatic patients undergoing CAS had a staggering 14.3% risk of stroke or death within the procedural window.
14.3%.
Compare that to a remarkably lower 2.7% risk for those undergoing CEA.
Let's just pause on that. 14.3% versus 2.7%. That is what, nearly a six-fold difference in the complication rate?
It is.
So for the listener, this means that even though our 75-year-old patient has COPD and a high risk of respiratory issues, she faces a significantly higher risk of having a procedural stroke if they choose the stent, because she's medically fragile.
And that's the conclusion for Dr. DeBourse. It's firm. The neurological dangers of the stenting procedure, the debris, the microemboli, the hemodynamic instability, they're all amplified in patients who are physiologically high risk.
So much so that the risk of a procedural stroke far outweighs the risk of death from surgical anesthesia complications.
That's his view. For this patient, CEA is the scientifically superior choice for stroke prevention.
That was a really compelling case for surgery based on foundational trial data. But now we have to pivot.
We do.
To expert 2, Dr. Fen Nguyen, who advocates for CAs. He acknowledges the CEA data, but fundamentally prioritizes minimizing risk for this specific patient.
Dr. Nguyen shifts the entire framework.
Yeah.
He says, look, while CEA is reasonable, CAS under conscious sedation is strongly advocated here because of the clinical, anatomical, and operator factors.
So it's all tailored to mitigating this patient's specific comorbidities.
Exactly. His core principle is risk management. You choose the path that avoids the most probable, immediate, and life-threatening complication for the individual in front of you.
And for a 75-year-old former smoker with COPD, That most probable immediate life-threatening complication is linked to the ventilator, not the clot.
Precisely. Dr. Green is essentially saying, we know the stroke risk might be slightly higher with stenting based on older data, but the respiratory risk for this patient with general anesthesia is non-negotiable and unacceptable.
So he's willing to accept a potentially higher neurological risk to avoid what he sees as a near-certain cardiopulmonary risk.
That's the trade-off he's making.
Okay, so let's delve into why the COPD risk trumps the procedural stroke risk in Dr. Green's estimation.
The patient's history, COPD, insulin-dependent diabetes, renal impairment, it just screams unstable recovery environment if surgery is done. When a patient is intubated for CEA, they need to be extubated and manage their own breathing pretty quickly after. If this patient's lungs, compromised by COPD, struggle,
They could end up with post-op respiratory failure, a long ICU stay.
ventilator-associated pneumonia. These are cascading failures that lead to high mortality, completely separate from the initial procedure.
And Dr. Nguyen sees that 3–4% risk of in-hospital death from the Euroscore 2 as a direct consequence of the anesthesia.
Yes, not the surgery itself, but the anesthesia required for it. By using conscious sedation with CAS, they eliminate the need for intubation and general anesthesia, and in his view, they neutralize her primary physiological vulnerability.
And he notes that this is supported by major guidelines.
It is. The American Stroke Association guidelines endorse this exact strategy, choosing conscious sedation via CAS to reduce periprocedural complications in patients who are specifically at high risk for general anesthesia.
So for him, the immediate clinical reality of the patient's lungs outweighs the statistical superiority of CEA in these big pooled long-term trials.
That's his position.
We mentioned earlier that the patient's anatomy was favorable for stenting. Dr. Nguyen uses this as a key factor to counter those high procedural stroke rates cited by the CEA side.
Yeah, favorable anatomy is critical to his argument. It tells him that he can likely achieve a complication rate far lower than the 7.3% or that scary 14.3% rate quoted earlier.
So let's review those features again.
Okay, 1, a type I aortic arch. That makes the catheter entry and navigation smoother, so you're less likely to knock plaque off the aorta itself.
Okay.
2, no tortuosity. A straight shot means less friction, less manipulation of the vessel walls. And 3, and this is the most crucial for neurological safety.
No dense calcification or clot.
Exactly. It suggests the plaque is relatively soft. And with modern embolic protection devices, or EPDs, the risk of releasing a large symptomatic embolus is drastically reduced.
So Dr. Nguyen is arguing that this patient is a best-case scenario for stenting, which mitigates the general risk profile of the procedure.
Precisely. If she had a heavily calcified plaque or a really twisty arch, Dr. Nguyen would probably agree that the procedural risks of CAS would climb too high to justify avoiding general anesthesia. But here, the anatomy aligns perfectly with minimizing the technical risks.
This brings us to the biggest piece of conflicting data in this whole thing,
Sure.
the stark difference in procedural stroke rates.
It really is the central conflict.
Dr. Nguyen counters that 7.3% rate from ICSS with data that reflects modern specialized practice. That's 7.3% procedural stroke rate. It's like the sort of Damocles hanging over the CAS argument. How does he justify his confidence that he can beat that number?
He argues that the ICSS data, while it's randomized and foundational, it reflects a time when operators were still on the learning curve, and the technology, the EPDs, were less refined.
So he sets a new goal.
He does. In a high-volume center with experienced neurointerventionalists, he says the expected periprocedural stroke or death risk should be less than 6%.
But he cites a study showing a much, much lower number than 6%.
Yes, he cites the Cassoni study. There's carotid artery stenting outcomes by neurointerventional surgeons.
So these are specialists.
Highly specialized. This isn't a generalized vascular surgeon. This is an expert whose entire focus is the brain and its vessels. And they followed over 1,400 patients treated exclusively by these specialists.
And what were their results? Give us the numbers that support the CAS argument.
They are strikingly low. The complication rates were for symptomatic ischemic stroke.
Yeah.
0.6%.
0.6%.
For symptomatic intracranial hemorrhage or bleeding, 0.3%. And for myocardial infarction or heart attack, 0.1%.
A 0.6% symptomatic stroke rate for CAS, that is in an order of magnitude safer than the 7.3% rate from the other side.
It is.
If that 0.6% rate is achievable, the entire premise that CEA is neurologically safer it falls apart. And CAS becomes the superior choice because it also eliminates the anesthesia risk.
It absolutely changes the calculus. That 0.6% rate is crucial because it indicates that in specialized hands, the neurological risk of stenting is comparable to, or maybe even lower than, the best procedural stroke rates from the early CEA trials.
So for Dr. Nguyen, the existence of the Cassoni data means the decision for this patient is solved.
He thinks so. Choose the path that protects her lungs because the modern neurological risk is minimal, at least at his center.
Okay, so we've established the argument for immediate safety. But what about the long-term risk of stroke? The CEA side emphasized that CEA gives up to a 4.1% absolute stroke prevention benefit over 9 years.
And the CAS side relies heavily on a different trial, the Carotid Revascularization and Endarterectomy versus Stenting trial, or CREST. CREST took a broader view. It focused on a composite primary outcome: stroke, myocardial infarction, or death.
Okay, why include MI and death in that primary outcome? Why not just focus on stroke, which is what we're trying to prevent?
Because they represent the overall mortality and morbidity burden of the intervention. While CEA might be better at preventing stroke, open surgery carries a higher risk of heart attack.
Probably from the stress of general anesthesia on an already compromised cardiovascular system.
That's the idea. So when you combine all the risks, what did CREST show?
What did it show?
CREST showed that the composite primary outcome did not differ significantly between the CAS and CEA patients. Not at the 4-year mark and not at the 10-year follow-up.
So while CEA had a lower rate of stroke,
CAS had a lower rate of MI. When you aggregated it all, the total adverse outcome rate was equivalent.
and for Dr. Nguyen, this long-term equivalence is the final piece of the puzzle.
It is. If the total burden of morbidity and mortality is the same in the long run, he argues the patient should choose the option that maximizes their immediate safety and minimizes the risk related to their most severe comorbidity, the COPD.
So he argues for CAS.
He does.
Okay, we have dissected two equally brilliant, data-driven arguments, and yet they stand. Well, they're diametrically opposed to the same patient. We need to step back now and address these inherent conflicts in the data. This is where the deep dive truly begins.
This divergence is exactly why personalized medicine is so challenging. The sources aren't lying, but they're drawing conclusions from different data sets that apply differently based on the clinical environment and the patient specifics.
Let's start with the central disagreement, the definition of high risk. Expert 1, the CEA advocate, said she's high risk for procedural failure, right? Citing that 14.3% stroke rate with CAS in high-risk patients. But expert 2, the CAS advocate, says she's high risk for anesthesia failure due to her COPD, which makes CAS the priority.
This is the risk definition disparity. It's a whole ballgame. Expert 1 uses clinical trial data that shows, historically, symptomatic patients with comorbidities who get a stent have disastrous neurological outcomes. 14.3% stroke or death.
Because their bodies are too fragile to handle the procedure?
Right. They believe the physiological fragility makes the patient unable to tolerate the microemboli inherent to stenting.
But expert 2 points out that the 3–4% mortality risk from general anesthesia because of her COPD is a known certain risk for this patient, whereas that 14.3% stroke risk might just be historical data that can be overcome with better technique.
Correct. It all boils down to the anesthesia versus procedural stroke trade-off. The core question is, which risk is this patient least likely to tolerate?
She's 75 with COPD, history of smoking. Her pulmonary reserve is likely poor.
So the risk of respiratory failure from general anesthesia is immediate and deadly. Dr. Nguyen believes avoiding that certain pulmonary catastrophe outweighs the potential for a higher but manageable risk of procedural stroke.
But Dr. DeBourse believes that 6-fold higher chance of procedural stroke, 14.3%, Busses says 2.7%, is just too large to ignore, no matter the anesthesia risk.
Exactly. So you're not just choosing a procedure, you're choosing which way the patient might fail. You're deciding whether you want the patient to face a respiratory death or a neurological disability.
We absolutely have to wrestle with this wild discrepancy in the CAS procedural stroke rates. The 7.3% from ICSS versus the 0.6% from that specialized Cassoni study.
Yeah.
How can a procedure's failure rate vary tenfold? And what does that mean for our patient?
This difference fundamentally dictates the choice. The ICSS trial, while it was a landmark study, included broad centers, operators with varying experience, older stent designs, and crucially, sometimes they didn't even use embolic protection devices.
So the 7.3% reflects the risk in a generalized, maybe less advanced setting?
I think so. So if our patient were at a community hospital of only to CAS infrequently, that 7.3% risk probably applies.
And in that case, the CA argument becomes overwhelmingly superior, despite her COPD.
Absolutely. The 7.3% versus the 3.3% for CEA remains the global reality in generalized practice, but the 0.6% rate from Cassoni highlights the impact of operator specialization.
These are dedicated neurointerventionalists in high-volume settings using all the latest gear.
The latest devices, balloon-guided catheters, distal protection filters, all designed to minimize debris traveling to the brain.
So Dr. Nguyen's argument for CAS only holds up if the hospital can reliably reproduce that 0.6% figure. If they're even slightly less specialized, that 7.3% figure starts creeping back into the equation.
That is the crucial connection. If the center can demonstrate the safety profile of 0.6%, then the argument pivots entirely to the anesthesia risk. If they can't,
Then the 7.3% procedural stroke risk, when compared to the 3.3% CEA risk, makes the surgery the safer neurological choice, regardless of the COPD.
it really shows that in modern medicine, the person performing the procedure is often as important as the procedure itself.
Okay, let's pull the lens back out to the long term and revisit the issue of silent ischemia. Expert 1 emphasized that 50% of CAS patients had new post-procedure lesions on MRI.
Right, and that it tripled their future risk of stroke or TIA finding that wasn't present in the CA group.
This finding is the long-term shadow cast by stenting, isn't it?
It is. CEA proponents argue this is clear evidence of microembolization during the stenting procedure that is permanently detrimental to the brain. Even if the patient avoids a major symptomatic stroke, they've suffered multiple small microscopic injuries.
And why should the listener care about silent ischemia if the patient doesn't feel it?
Because cumulative silent ischemia is linked to long-term cognitive decline and vascular dementia. For a 75-year-old woman who is still fully independent with no cognitive impairment, preserving her cognitive function is paramount.
So the CREST trial showed equivalence in that composite endpoint, but it doesn't account for potential differences in long-term cognitive integrity.
It doesn't. So the CEA argument essentially states, we remove the source of the plaque completely, which is safer for the brain in the long run, even if it carries a higher immediate respiratory risk.
They argue the trade-off is long-term cognitive function for short-term anesthesia safety.
Yes. If the patient has a long life expectancy, and this independent 75-year-old may well have a decade or more of quality life left, then the higher rate of silent brain injury with stenting becomes a very strong argument against it.
It seems like the decision for this specific patient hinges entirely on whether the doctor fears respiratory failure more than they fear a procedural stroke and long-term brain injury.
That's the entire synthesis. It's an exercise in prioritizing failure modes. If the patient's COPD is truly debilitating, if she struggles to walk across a room, the anesthesia risk is catastrophic. That favors CAS.
But if her COPD is mild and manageable, and the hospital can't demonstrate those key center level stroke rates,
Then the overwhelming stroke data favoring CEA and the avoidance of silent ischemia makes surgery the superior choice.
this has been a profound exploration into the intersection of technology, trial data, and, well, individualized patient risk. For this 75-year-old woman, the clinical team faces a monumental choice where the data is both conclusive and contradictory.
Yeah, to summarize the key takeaways for you. First, CEA, surgery. It provides the most robust evidence for long-term absolute stroke prevention, and it minimizes the neurological burden of silent ischemia, 50% versus 17% new lesions. But it forces the patient to undergo general anesthesia, which poses a severe and potentially fatal risk to her compromised pulmonary system because of the COPD.
Okay, and on the other side?
CAS stenting eliminates that respiratory risk by using conscious sedation, which Dr. Nguyen sees as essential for this patient. Its long-term total morbidity stroke, MI, death is equivalent to CEA in the major CREST trial.
But its viability is entirely dependent on the center's specialization.
Entirely. Success rates can range wildly from 7.3% all the way down to 0.6%, making it a highly center-dependent procedure.
Ultimately, the physician has to make a choice rooted in deep clinical experience. Do they rely on the superior neurological safety shown in decades of CEA trials and accept the respiratory risk?
Or do they prioritize the patient's immediate physical vulnerability, her lungs, and rely on the modern hyper-specialized success rates of CAS, accepting the long-term risk of silent ischemia?
It's a tough call.
The final provocative thought for you to consider is this. When treating symptomatic carotid stenosis, the decision isn't purely about averaging risks across a population. It's about identifying the patient's single weakest link, their Achilles heel.
Right.
For our patient, that weakness is likely her lungs. However, the data strongly suggest that in medically high-risk patients, the sheer invasiveness of stenting, with that 14.3% stroke risk in those symptomatic high-risk cohorts, is a failure mode that the body is even less equipped to handle than the temporary stress of general anesthesia. So the physician has to determine if their hospital's CAS program is truly performing at a Cassoni level, at that 0.6% level, or if they're forced to confront the statistical reality that avoiding the general anesthesia risk might actually invite a higher and more permanent neurological disaster.